Hi everyone, I'm Dr. Samara Rashid, and today we'll be talking about infection control rationale and regulation. And this is found in Chapter 8 of the textbook named Infection Control and Management of Hazardous Materials for the Dental Team, with authors Chris Miller, the 5th edition, 2014. So infection control was designed to prevent or at least reduce the spread of disease agents from the following: patient to dental team to patient, patient to patient, from the dental office to the community, and from community to patient and dental team to family. Especially after the recent events of coronavirus being spread, a lot of this pertains to the community in general in regards to the public. But the dental team has been practicing this from day one. The logic for routinely practicing infection control is that the procedures involved interfere with the steps in development of diseases that may be spread in the office. There's two forms of contact with infection control. There is direct contact and indirect contact. So with direct contact, for obvious reasons, as the name states, it involves touching, a physical encounter with the patient's saliva or blood, and it could lead to the entrance of microorganisms through non-intact skin, resulting from cuts, abrasions, or dermatitis. So, I mean, I'm not just talking about simple touching. I mean, I'm talking about, let's say there's a break in your skin and you come in contact with such microorganisms. And because of that, that could lead to entrance, causing issues in the future. Indirect contact is the transfer of microorganisms from the source to an item or surface and subsequent contact with the contaminated item or surface. Okay. Infection control procedures to prevent patient to dental team spread are listed in Table 8-1. Okay, this is Table 8-1 from the same infection control textbook. It's a slew of information, but it just goes to show how important it is, and how detail-oriented infection control can be. And you see in the first column, the pathway of cross-contamination from patient to dental team, for example. And then you see the source of the microorganism, which is the patient's mouth, obviously. And then the mode of transition could be direct contact. It could be droplet infection, indirect contact. And droplet infection is a big one, especially nowadays with the COVID-19 that's been going on. And then you look here and you see the mechanism or the site of entry into the body. And just because of the current times, if you've noticed, droplet infection, when you inhale it, inhalation by the dental team, and that's when, currently the CDC could be recommending, at least at the time of this recording, the CDC is recommending, N95 masks or whichever. Whatever the case may be, the mask is what is truly important, okay? And you'll see the procedures: mask, rubber dam, mouth rinsing. And we want to make sure that the source of the microorganism, which is the patient's mouth, be clean. So you're going to wonder why, mouth rinsing? It doesn't really occur, but, to many people in the public. But with you guys, as part of, now you're part of the dental team, now you understand that, having a clean mouth to begin with is very helpful in, a little bit of decreasing the spread of the infection. And then on top of that, if you use something called a rubber dam, which many dentists or dental providers use when they're doing a filling or placing a crown or anything of the matter, the rubber dam also acts as a barrier and prevents transmission of any germs or droplets that come from the patient's mouth and to the dental team. And then of course the mask is the big one with us wearing the mask. That's the really big one. Really review this, make friends with it. It's pretty good, in a sense of being familiar with it and seeing how it pertains to your profession. Okay, so this one, Table 8-1, the mechanisms of disease spread and prevention, the pathway of cross-contamination, again, from office to community, dental team to family, community to patient, And then, you know, like for example, with community patient, we've got municipal water, you know, something like that. You would think, you wouldn't even think about, you know, that the municipal water could be a source of microorganisms. Okay. But you know, go ahead and review this. Make sure again, you know, it's not so much of that the fact that oh it comes from an old book or whichever. It still is valid, and there's not much change to this because in the end of the day, germs are spread. We've been doing this for quite some time now. Okay, the goal for infection control. Why do we do it? Well, the goal of infection control is to reduce the dose of microorganisms that may be shared between individuals or between individuals and contaminated surfaces. We want to decrease as much transmission as we can. We want to also enhance our resistance to infectious diseases through specific immunizations. But immunizations are not available against all diseases and that we would like to prevent. Okay. You know, of course, there's many ways that we can, you know, put our armory on and say, okay, I don't want to get such and such infection. I don't want to get sick because, God forbid, if the patient is sick. Well, you know, if you take these measures all the time and you apply this to all patients, you know, your chances of transmission will decrease. Okay. You'll remember that when we take our hepatitis B vaccine, that also protects you from getting the hepatitis B from patients. The only disease determinant we can manage effectively is the dose. And management of the dose is called infection control. Okay. Instrument pre-cleaning, and we're gonna go into this later on in our in the program. Instrument pre-cleaning and sterilization eliminate or reduce the number of microorganisms that could be spread from one patient to another. It's almost like saying you take the dishes, you put it in the sink, you soak them, then you take them out, and then you clean them with, you know, with you know, a sponge or whichever, using your dishwashing liquid. And then it's almost like saying you take that and then you put it in the dishwasher. So, you know, in terms of steps, there's something similar in that sense. Of course, not in the sense of what is sterilized. So there's instrument pre-cleaning, meaning we brush off the debris that's on the instruments after they've been exposed to the patient or used on the patient. And then we go ahead and put them in the ultrasonic machine. It's a machine that often cleans jewelry, like you might have seen them in a jewelry shop, and it vibrates, okay? And a lot of the extra debris is shaken off in this solution. And then after that, it's drained and it's wrapped up in these cassettes and placed in an actual sterilizer. And that's, you know, when you follow those steps, that's what really reduces the number of more microorganisms immensely. And then ultimately the sterilizer wipes them all out. So some state and local regulations exist in relation to medical waste management, instrument sterilization, and sterilizer spore testing in dentistry. 26 states also have their own division of OSHA in their state departments of labor. And it's important for the dental team to keep in contact with various state agencies for the latest information that may affect infection control in the dental office. Okay. When it comes to the FDA, part of the United States Department of Health and Human Services, you know, a lot of people don't realize that the FDA is not just Food and Drug Administration. They play a part in infection control regulations also. And then we also have the EPA and of course OSHA. We mentioned these agencies in previous lessons. The EPA is associated with infection control by attempting to ensure the safety and effectiveness of disinfectants, because we want to make sure what is the effectiveness of what you're using on the countertops or whatever you're cleaning. With OSHA, that's the division of the U.S. Department of Labor, and its charge is to protect the workers of America from physical, chemical, or infectious hazards in the workplace. So we have bloodborne pathogen standard, okay? And this is gonna be one of your best friends, you know, throughout your whole career. It was published in '91, and it's mandatory for every dental office to have a copy of a blood pathogen standard, or a BPS. The standard, this serves as like the standard for protection against occupational exposure to blood-borne pathogens. In other words, what would happen if, for example, I got a finger stick? You know, if I was cleaning instruments or I was working on a patient and I was taking the needle or something, or an instrument cut me, what would be what would be part of my protocol, okay? So this indicates that the employer has a responsibility to protect the employees from exposure to blood and other potentially infectious materials in the workplace, and to give proper care if an exposure actually occurs. There has to be some sort of protocol. It applies to employers in any type of facility in which employees have a potential for that exposure to body fluids, including dental and medical. So dental, clinical, and research labs, hospitals, even funeral homes, emergency med services, nursing homes, and others. So it's not just dental. There's a slew of places that have stuff like this. The most important infection control law is in dentistry. So this is the most important infection control law in dentistry, in blood pathogen standard. Okay, there's a box in the same textbook, box 8-1. It talks about the OSHA bloodborne pathogen standard, the general steps for compliance. You got to review the standard, prepare a written exposure control plan, train your employees, provide employees everything needed to comply with the standard, offer the Hep B vaccine in a series, provide, maintain, dispose of, or even clean, and ensure use of the PPE and or engineering controls, establish appropriate work practices and decontamination procedures. You have to definitely establish a post-exposure medical evaluation and follow-up. So, you have to do all these in step by step, and no matter what, the employer must document, sent employee here, offered this, employee rejected this, or did not wish to further pursue. I mean, these are all things that are just part of the compliance. Okay, your book talks a little bit about the OSHA written exposure control plan even further in box 8-2 in regards to a written plan and what it documents and what it entails. And you'll see it has the exposure determination, the schedule of implementation, evaluation of the exposure incidents. So, they want to make sure, do you know what you're doing? OSHA is saying, do you understand in regards to how would you follow up if, God forbid, something bad happened? This is the protocol, and what is your protocol, and do you have it ready? Okay. So a written plan is prepared by each dental office, clinic, or school that contains the elements in this box 8-2. It must be reviewed and updated at least annually, and a copy must be accessible to all employees for obvious reasons. It refers to exposure incident management of a dental healthcare worker to bloodborne pathogens, bloodborne disease-causing organisms. Okay, so there's a little bit about talks of the exposure determinations. Okay, first of all, it's necessary of the fact of a couple of things. So survey all the tasks performed by all the employees. Make a list of all job classifications in the office where all the employees in that classification have occupational exposure. For example, a dentist, a dental hygienist. This can be category 1. Okay, it can kind of we can divide it up. That could be category 1. But then there's a second list of job classifications, and in that class, they may have occupational exposure, okay? And that's the receptionist, office manager, and that could be labeled as category 2. So in category 1, they could have occupational exposure, and in category 2, for example, they might have an occupational exposure. The employer must make these determinations as if glove, masks, eyeglasses, and protective clothing are not being used. Okay, because you have to pretend okay, is this completely, I guess you could say completely proofed without having to do with any PPE that's on. Employees in these job classifications in the first and second categories would be covered under the standard. So this would be part of overall your exposure control plan. Follow-up measures are also important. So follow-up measures for exposed personnel would include something like documentation of the incident, appropriate counseling, services provided at no charge. If the personnel is exposed, the employer has to evaluate circumstances surrounding the moment or incident, the route of exposure, was it through the skin, was it in the eyes, the patient's source, was it through the mouth, was it spit? Was it, a teardrop? I mean, you really have to get really detailed. Types of barriers warned at time of the exposure. Was the personnel that got exposed, were they wearing gloves at the time? So If they had a needle stick, for example, a needle went into through their skin, did it go through the glove and then into their finger and through the finger? Example, okay? So what was the employee doing at the time of exposure? Were they working on the patient? Were they in a were they in the sterilization room, cleaning instruments? Okay? And no matter what, there should be an incident report form that must be documented, and that's the best way to have documentation. Okay, an example of an exposure control plan doesn't have to necessarily look like this, but this is an example of that. Okay, and this is from your book as well. Look, if you notice, it has the questions that we just talked about in the previous slide. Okay, and box 8-5, also here from your book, the post-exposure medical evaluation and follow-up. I put a cutout of here, this, about in regards to the employer, employee, healthcare professional. And, this will tell you that, ensures that test results of the source individual are given to the healthcare professional, reports to the healthcare professional for evaluation. It has a whole bunch of detail. And again, these type of control plans have to be detailed. It's important because there's a lot at stake. Okay, a little bit about the hepatitis B vaccine or the B vaccination. Once the training is received by the OSHA standard, employees must be offered the hepatitis B vaccination or the booster. It's free of charge. It's within 10 days of their employment, and it can be declined by an employee. So, they do have the right to say, I don't want it, but it's got to be documented. And if it's initially declined, okay, or they decide to accept the offer later on, then the employer must make the vaccine available at no charge at that time. It can't be like, no, I offered it one time, it was free at that time, now you have to go and pay for it. No, it's got to be free even if they change their mind later on. Okay, a little bit of talks of the hepatitis B vaccination. Your book has a box 8-4 in regards to it. It gives a copy, the employer gives a copy of the OSHA standard. It provides vaccine-related training to the employee and offers the series. In regards to the employee, for example, they receive the vaccine-related training. They receive the free offer of the vaccine. In terms of the healthcare professional, they receive a copy of the OSHA standard form. It evaluates the employee for vaccination. It gives written opinion to the employer on evaluation and if the vaccine was administered. Okay, so there's a lot of detail again with this, and you can find this in the textbook as well. Universal precautions. This is something, you will practically be like, the right-hand person of this throughout your career. Since I've been practicing dentistry, universal precautions is my middle name. So universal precautions is the concept that all human blood and certain human bodily fluids that may contain blood are treated as if known to be infectious for HIV and HPV and with other blood-borne pathogens. In other words, universal precautions is like treating everything as though it is the worst possible disease on the planet. That's called universal precautions. Not just, oh, it's a little bit of saliva here, oh, it's a teardrop there, it's a little bit of blood here. No, it's all the worst. Oh my gosh, it's the worst ever, for example, okay? So the CDC has expanded the concept of universal precautions into what is now called standard precautions, SP. Okay, so they call it standard precautions. Standard precautions applies not just to contact with blood, but also to all bodily fluids that we mentioned. All secretions, excretions, except sweat, regardless of whether they contain blood. Non-intact skin, okay, non-intact skin, mucous membrane. Okay, so the CDC published its current infection control recommendation for dentistry in 2003. It categorizes each of their recommendations depending on the scientific evidence available to support the recommendation. So CDC goes by, what does the evidence say? Okay, if you remember, even with coronavirus, when it first came out, there was a lot of uncertainty. Plus the CDC kept saying, we don't know yet, we're not sure what to do yet, so take all measures, because they're all about scientific evidence. Categories are included with the recommendations presented in the Appendix B of the Infection Control and Management of Hazardous Materials for the Dental Team. So it's also present in your Appendix B, up for review. You can review that at any time. The CDC also ranks a little bit of, ranks a little bit of these issues. So you have category 1A, category 1B, category 1C, category 2, unresolved issues. Okay. So again, this is very important because this will determine the rankings. Okay. Or the severity of it. So category 1A is basically, it's strongly recommended for implementation. It's strongly supported by a well-designed experimental, clinical, or epidemiologic studies. So this is something, okay, we've got the evidence, here it is, this is in category 1A. Then there's category 1B. So it's strongly recommended for implementation. It's supported, but not strongly, but supported by experimental, clinical, or epidemiologic studies and a strong theoretical rationale. Okay, so you see the difference between 1A and 1C. And then we have category 1C. It's required for implementation as mandated by federal or state regulation or standard. Then you have category 2. Okay, so you're out of the 1, now you're in category 2. It's suggested for implementation. Okay, supported by suggestive clinical epidemiologic studies or a theoretical rationale. So you see the difference as you go down, it gets less and less intense. And then of course we have the unresolved issue, meaning there's no recommendation. Practices for which there is insufficient evidence. Okay, and then this is your textbook. Again, it's the 5th edition of the 2014. It's by the author, Chris Miller. Thank you so much.